I'm going to talk about the development of surgery in Sierra Leone, and also our task sharing project there. I'm chairman of CapaCares. I'm a little bit biased there, and I'm also been doing research on this initiative, and I myself are a surgeon. What I will talk about briefly, I will not talk very long. I will say a little bit about human resources in low-income countries. I will say a little bit about surgery in Sierra Leone, and a little bit about task sharing, and how we have been doing, what we have been doing in Sierra Leone, and then the concept of task sharing, which we are actively promoting, the opportunities, challenges, and some of the knowledge gaps that we think it's important to be filled. In low-income countries, 30-something, 31, 32 countries, there was a population last year of 650 million people. And the Lancet Commission that Lars talked about, they have defined a minimum need of specialists to be 20 per 100,000, which gives a need of around 130,000 surgical specialists, obstetricians and anesthesiologists in those countries. And the group in Lund, they contacted ministries of health around the world and calculated actually how many are there, and found out that it was 0.7 per 100,000, around 4,000 of this group. So it's a lack of 120,000. This is the present situation. This is also the countries in the world with the highest population growth, and in 2030 it will be close to 1 billion people living in those countries, and you will have a need of close to 190,000 of those specialists. So it's certainly, we have a challenge there. We have a tremendous challenge to be able to deliver those services if we rely on those people altogether, and that's what we have looking into. What kind of other possibilities are there? And what are the consequences of those huge gap in surgical providers? We mapped Sierra Leone a few years ago and found that it was done 400 surgeries per 100,000 population. And in high-spending countries, on average, it's done around 11,000 operations per 100,000 population per year. We calculated the need in Sierra Leone, quite a conservative need, and the red is the need. So that is not what is not done every year. It's more than 300,000 operations that are not done every year. And who are they? It's we saw some pictures from Lars, and I have to show some of this to you also. Abscesses, simple things, tooth abscesses. This woman, she was in her 20s, she died a few days after this picture. It started with an infection of a tooth. Cancers we have talked about. Women in Africa, they come with the cancer 10 years earlier than European women. This woman also, she died from it. She knew that this was something really, really bad with her breast, but she couldn't afford it. Children with burns we have talked about. This guy, he was 19 years old. He has been walking with this hand for 3 years. He wasn't able to go to a health facility, and likely he wasn't able to pay for it. So this is what people need to deal with. We talked about it. It creates poverty. It hampers development, and of course the human suffering. We can all imagine what this is. This is a month ago. A 19-year-old boy. He came to one of the district hospitals in Sierra Leone. He had pain in his abdomen, and they diagnosed it with an appendicitis. They made an operation. They found a rather red appendix, so they removed it. Sorry, he didn't recover. So after 4 days, they did another operation. They found a perforated small bowel, and they closed the hole. It went another week, he didn't recover. They did another operation. They removed part of the small bowel and the large bowel and joined it together in an anastomosis. And then one of our guys he was based in this hospital, he said that you cannot suture that together, it will fail. And he was thrown out of the operation theater. You're not allowed to give us lessons like that. So he was thrown out. And 1 month later, that boy came to Masanga hospital, and we did a new operation, gave him a stoma, and brought out the intestines, but he died the day after. So even if you do surgery, there is a lot of quality issues on surgery. This would be a very, very simple thing to change during the first operation, during the second operation, maybe even during the third operation you could have likely saved it. So the challenges we face in West Africa is the highest burden of untreated surgical conditions, and it has the lowest number of surgical providers per capita in the world. This is the reality we are facing. It's lack of qualified human resources is one of the main contributing factors, and there is limited knowledge about the quality of surgical care. What is task shifting? We are talking about that. We are promoting that maybe could we teach somebody else to do surgery? So task shifting or task sharing is a rational redistribution of tasks, where specific tasks are moved from someone with higher qualification to someone with lower qualifications, and then you train them. This was highly successful during the HIV epidemic and been widely implemented, but not so much in surgery still. CapaCare and the Masanga project, this is the concept how we like to see ourselves. It's a triangular relationship. The Ministry of Health is our main partner, which we work together with. And we have an operational part and we have an academic part. CapaCare do the operational activities, the training, and we do the evaluation and the research and gathering data on the academic part. And this is, we have several institutions for which we collaborate with. And also on the operational side, UNFPA and also help us implement policies. And so this is the way we have been thinking. And I'm really looking forward to take this further with the research unit. What do we believe in? What is our core strategies in Sierra Leone? It's the collaboration with the Ministry of Health. I touched upon that. We also need to use maximum use of the national resources. And that's the reason why we have created a network of partner hospitals. So we train in all the hospitals on the dots there. It's around 20 hospitals in Sierra Leone. We want to give priority to district hospitals because we think that the most vulnerable populations are living there. We promote task sharing, and research is a core of our activity. If we want to change things, if we want to implement new things, it's a trial situation, and we have to know what we are doing and publish the result, good or bad ones. How do we train our task-shifted providers? So this is we have a pre-training and we're training internship, and then they come surgical assistants, community health officers. This is the timeline. We have certain modules, the same one that goes every year. They are evaluated rigorously throughout the training. They are trained in Masanga here. They are assessed in Masanga, and then they are rotation to partner hospitals, internship in the major training institutions in the capital. And they have exams. Yeah, and the Ministry of Health is involved in key steps, the selection of candidates, the final exams, the supervision at the internship, and they replace them when they are finished. So that's how the ministry is involved in the project. We use core curriculums developed by the WHO and other recognized institutions. It's theoretical teaching. It's skills lab where you teach practical skills. We invent a lot. This goes from very, very basic to hopefully a bit more advanced after a while. But you can suture uteruses and practice on that. So it's all kinds of stuff. Banana leaves, yeah, all kinds of stuff are used. Group training and scenario trainings are heavily used. We give pigs anesthesia and do trauma and resuscitation training. orthopedics, ultrasound, and a lot of practical training. So all of them are trained here. The one who are looking are the newest one, the one who performed the surgery. There is a trainer, and there is a scrub nurse who is actually also one of the trainers. And sometimes they swap roles when they are more advanced. They can teach the other ones. So what is the quality? What do we know so far about the quality of when non-physicians are doing surgery? We have taken cesarean sections as a procedure because it's well researched, and we knew from before that MSF did a study some years back, a small study, 300 women, cesarean sections, and they had 4 deaths. Recently, a large publication from West Africa, it ranged from 0.4 to 4% mortality after cesarean section. Our students in training is based on more than 6,000 cesarean section, and they had 0.7, and the graduates have 0.4. You can criticize the methodology, and Alex will talk about how we are trying to do another study to see if this is reasonable. But the indications we have so far is that this is a safe way of expanding surgical care. What are the opportunities for task sharing? It's cost and time saver, we know that. It has shown that it increases and retention at district hospitals. Outcomes seems to be similar to medical doctors, at least for some procedures. And it fits well with countries with a narrow scope of operations performed. And some have even stated that around 85% of the surgical procedures performed in low-income countries is suitable for task-shifted or task-shared providers. We saw in Sierra Leone that 65% of all the operations were only 3 surgical procedures: a hernia repair, cesarean section, and an appendectomy. It's hard to believe that you can have a significant increase in surgical volume in low-income countries without adapting this as part of the strategy. This is only part of the solution, of course. And we believe that it targets marginalized and underserved population. There are many challenges. Those to be trained, they have all kinds of different names, various length of training. So it's difficult to unite this group. The training curriculum that goes on in different countries are quite, they vary quite a lot. Regulation of their activity afterwards is a big issue in several countries, also in Sierra Leone where we are working. It's still highly disputed, and those who are trained have a difficult career progression. Does this provide some breakdown of professional roles? It's a question that needs to be discussed. And in places where this practice is neither regulated, it also, at the end of the day, gives poor acceptance. And sometimes it also creates tensions between medical doctors and non-medical doctors who is performing surgery. The knowledge gaps that we want to do as NTNU and CapaCare, and also have invited others, collaborating academic centers, to answer in the future is we want to look if this has implication on access to surgery. We want to see further quality of surgical care, and we are looking specifically on cesarean sections and laparotomies. We want to see if it gives an equity impact, and what happened with referrals when this new group start, and also the cost of surgery, cost for hospitals and cost for the patient. Lastly, I want to say thank you to the Masanga group for you see the bow ties we have here. It was also given as a present to our graduates when they finished. So there is a link definitely. So thank you the whole Masanga family for hosting this and also letting us be part of the family. Thank you.